Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of lectures of prime neurology. There are going to be 50 episodes of prime neurology, and if one listens to all these 50 episodes of prime neurology, one would have acquired a good knowledge of neurology. Right now we are on part 44, prime neurology, trigeminal neuralgia, Bell's palsy and other cranial nerve disorders. So today in this episode we are going to discuss trigeminal neuralgia, Bell's palsy and other cranial nerve disorders. Trigeminal neuralgia, frequent excruciating paroxysms of pain in the lips, gums, cheek or chin, rarely in the ophthalmic division of the fifth nerve, lasting seconds to minutes. Typically presents in middle or old age. Pain is often stimulated at trigger points. Sensory deficit cannot be demonstrated. Must be distinguished from other forms of facial pain arising from diseases of jaw, teeth or sinuses. Pain from migraine or cluster headache tend to be deep-seated and steady, unlike the superficial stabbing quality of trigeminal neuralgia. In temporal arteritis, superficial facial pain is not shock-like. Patient frequently complains of myalgias and other systemic symptoms and an elevated erythrocyte sedimentation rate or C-reactive proteins usually present. Rare causes are herpes zoster or a tumor. An onset in young adulthood or if bilateral raises the possibility of multiple sclerosis. The three major sensory divisions of the trigeminal nerve consist of ophthalmic, maxillary and mandibular. You can see the ophthalmic division extending backwards. Treatment of trigeminal neuralgia. Carbamazepine is effective in 50 to 75% of cases. How come carbamazepine, which is an anti-epileptic drug, effective in neuralgia? It is effective in neuralgia because carbamazepine is a sodium channel blocker. So it inhibits the sodium impulse so that the pain impulses are not transmitted effectively. Since it's a sodium channel blocker, it is effective in neuralgic pains. So carbamazepine is effective in 50 to 70% of cases. Begin at 100 mg single daily dose taken with food and advance by 100 mg every 1 to 2 days until substantial more than 50% pain relief occurs. Most patients require 200 mg 4 times a day. Doses more than 1200 mg daily usually provide no additional benefit. Oxcarbamazepine 300 to 1200 mg BID is an alternative with less bone marrow toxicity and probably similar efficacy. For non-responders, lamotrigine 400 mg daily, phenytoin 300 to 4 mg per day or baclofen initially 5 to 10 mg 3 times a day can be tried. When medications fail, surgical microvascular decompression to relieve pressure on trigeminal nerve can be offered. Other options include gamma knife radiosurgery and radiofrequency thermal rhizotomy. Trigeminal neuropathy usually presents as facial sensory loss or weakness of jaw muscles. Causes are varied, including tumors of the middle cranial fossa or trigeminal nerve, metastasis to the base of the skull, or lesions in the cavernous sinus affecting first and second divisions of the fifth nerve, or superior orbital fissure affecting the first division of the fifth nerve. So you can see here the trigeminal nerve disorders. It could be nuclear brainstem lesions, it could be preganglionic lesions, it could be Gasserian ganglion lesions, it could be peripheral nerve lesions. We're done with trigeminal neuralgia. Now we'll talk about facial weakness. Look for hemifacial weakness that includes muscles of the forehead and orbicularis oculi. If lesion is in the middle ear portion, taste is lost over the anterior 2/3 of the tongue and there may be hyperacusis. If lesion is at internal auditory meatus, there may be involvement of the auditory and vestibular nerves. Pontine lesions usually affect abducens, sixth cranial nerve and often corticospinal tract. Peripheral nerve lesions with incomplete recovery may produce continuous contractions of affected musculature, facial myokemia, contraction of facial muscles on attempts to move one group selectively, synkinesia, hemifacial spasms, or anomalous tears when facial nerves activated as in eating, example crocodile tears. Facial nerve. Here we can see the facial nerve as it descends. So the lesion may occur at this level A or B or C. The facial nerve A, B, C denote lesions of the facial nerve at the stylomastoid foramen, distal and proximal to the geniculate ganglion respectively. So the green lights indicates the parasympathetic fibers, the red lines indicate motor fibers, and the purple fibers indicate visceral afferent taste. So we have to find out where the lesion is, whether it is at the stylomastoid foramen, distal or proximal to the geniculate ganglion. Bell's palsy, the most common form of idiopathic facial paralysis affecting 1 in 60 persons over a lifetime. Association with herpes simplex virus type 1. Risk factors include pregnancy and diabetes mellitus. Weakness evolves gradually with maximal weakness by 48 hours, sometimes preceded by retrooral pain. Hyperacusis may be present. Full recovery within several weeks or months in 80%. Incomplete paralysis in first week is the most favorable prognostic sign. Diagnosis can be made clinically in patients with a typical presentation, no risk factors or pre-existing symptoms for other causes of facial paralysis, no lesions of herpes zoster in the external ear canal, a normal neurologic examination with the exception of the facial nerve. In uncertain cases, an ESR or CRP, testing for diabetes mellitus, a Lyme titer, angiotensin converting enzyme level, and chest imaging study for possible sarcoidosis, a lumbar puncture for possible Guillain-Barré syndrome, or MRI scanning may be indicated. Treatment. Protect the eye with the paper tape to depress the upper eyelid during sleep and prevent corneal drying. Artificial tears. Massage of the weakened muscle may help symptomatically as well. Prednisone 60 to 80 milligrams per day over 5 days, tapered off over the next 5 days, modestly shortens the recovery period and improves functional outcome. Large randomized trials found no added benefit for valacyclovir or acyclovir compared with glucocorticoids alone. For patients with permanent paralysis, cosmetic surgical procedures can restore a relatively symmetric appearance to the face. Other facial nerve disorders. Ramsay-Hunt syndrome is caused by herpes zoster infection of the geniculate ganglion, distinguished from Bell's palsy by vesicular eruption in the pharynx and external auditory canal, and by frequent involvement of the 8th cranial nerve. Acoustic neuromas can often compress the 7th nerve. Infarcts, demyelinating lesions of the multiple sclerosis, and tumors are common pontine lesions. Bilateral facial weakness can occur in Guillain-Barré syndrome, sarcoidosis, Lyme disease, and leprosy. Hemifacial spasm may occur with Bell's palsy, compression and or demyelination of the nerve by tumor, infection, or multiple sclerosis, or as an idiopathic disorder. Blepharospasm consists of involuntary recurrent spasms of both eyelids, usually occurring in the elderly, and sometimes with associated facial spasm, may subside spontaneously. Hemifacial spasm or blepharospasm can be treated by injection of botulinum toxin into the orbicularis oculi. Other cranial nerve disorders. Disorders of sense of smell. Olfactory nerve. The first cranial nerve disorders are due to interference with the access of the odorant to the olfactory neuroepithelium, transport loss, injury to the receptor region, sensory loss, or damage to the central olfactory pathways, neural loss. Most common causes of olfactory disorders are aging, severe upper respiratory infections, head trauma, and chronic rhinosinusitis. Although more than half of people between 65 and 80 years of age suffer from olfactory dysfunction that is idiopathic, it is increasingly recognized that a number of neurodegenerative disorders are accompanied by olfactory impairment. Patient often presents with a complaint of loss of sense of taste even though their taste thresholds may be within normal limits. Disorders of sense of smell. Therapy for allergic rhinitis, bacterial rhinitis and sinusitis, polyps, neoplasms and structural abnormalities of the nasal cavities is usually successful in restoring the sense of smell. There is no proven treatment for sensory neuronal olfactory losses. Fortunately, spontaneous recovery can occur. Cases due to exposure to cigarette smoke and other airborne toxic chemicals can recover if the insult is discontinued. Preliminary data suggests that patients with hyposmia may benefit from repeated smelling of odors such as eucalyptol, citronella, eugenol and phenyl ethyl alcohol over weeks to months. The usual paradigm is to smell odors before going to bed and again upon awakening each day. The use of zinc and vitamin A is controversial and there does not appear to be much benefit beyond replenishing established deficiencies. Now let's talk about glossopharyngeal neuralgia. This neuralgia involves the 9th glossopharyngeal and sometimes portions of the 10th vagus cranial nerves. Presents with paroxysmal intense pain in the tonsillar fossa of the throat that may be precipitated by swallowing. There is no objective sensory or motor deficit. Other diseases affecting this nerve include herpes zoster, multiple sclerosis or compressive neuropathy due to tumor or aneurysm in the region of jugular foramen when associated with vagus and accessory nerve palsies. Treatment of glossopharyngeal neuralgia. Medical therapy is similar to that for trigeminal neuralgia and carbamazepine is generally the first choice. If drug therapy is unsuccessful, surgical procedures including microvascular decompression if vascular compression is evident or rhizotomy of glossopharyngeal vagal fibers in the jugular bulb are frequently successful. Dysphagia and dysphonia. Lesions of the vagus nerve 10th nerve may be responsible. Unilateral lesions produce drooping of the soft palate, loss of gag reflex and curtain movement of the lateral wall of pharynx with hoarse nasal voice. Etiologies include neoplastic and infectious process of the meninges, tumors and vascular lesions in the medulla, motor neuron disease, example amyotrophic lateral sclerosis or compression of the recurrent laryngeal nerve by intrathoracic processes. Aneurysm of the aortic arch, an enlarged left atrium and tumors of the mediastinum and bronchi are much more frequent causes of an isolated vocal cord palsy than are intracranial disorders. A substantial number of cases of recurrent laryngeal nerve palsy remain idiopathic. With laryngeal palsy, first determine the site of lesion. If intramedullary, there are usually other brainstem or cerebellar signs. If extramedullary, the glossopharyngeal 9th and spinal axillary 11th nerves are frequently involved. Jugular foramen syndrome. If extracranial in the posterior laterocondylar or retroparotid space, there may be combinations of 9th, 10th, 11th and 12th cranial nerve palsies and a Horner's syndrome. If there is no sensory loss of the palate and pharynx and no palatal weakness or dysphagia, lesion is below the origin of the pharyngeal branches which leave the vagus nerve high in the cervical region. The usual site of disease is then the mediastinum. Neck weakness. Isolated involvement of the accessory 11th nerve palsy. 11th nerve can occur anywhere along its route, resulting in paralysis of the sternocleidomastoid and trapezius muscles. More commonly, involvement occur in combination with the deficits of the 9th and 10th cranial nerves in the jugular foramen or after exit from the skull. An idiopathic form of accessory neuropathy similar to Bell's palsy has been described. Most patients recover, but it may recur. Tongue paralysis. The hypoglossal 12th nerve supplies the ipsilateral muscles of the tongue. The nucleus of the nerve or its fibers of exit may be involved by the intramedullary lesions such as tumor, poliomyelitis or most often motor neuron disease. Lesions of the basal meninges and the occipital bones, platybasia, invagination of the occipital condyles, Paget's disease may compress the nerve in its extramedullary course in the hypoglossal canal. Isolated lesions of unknown cause can occur. Atrophy and fasciculation of the tongue develop weeks to months after interruption of the nerve. Multiple cranial nerve palsies. Approach to the patient. First determine whether the process is within the brainstem or outside it. Lesions on the surface of the brainstem tend to involve adjacent cranial nerves in succession with only late and slight involvement of long sensory and motor pathways. The opposite is true of processes within the brainstem. Involvement of multiple cranial nerves outside the brainstem may be due to trauma, localized infections including varicella zoster infection, infectious and non-infectious, especially carcinomatous cause of meningitis, granulomatous disease such as granulomatous with polyangiitis, Behet's disease, vascular diseases including those associated with diabetes, enlarging aneurysm or local infiltrating tumors. A purely motor disorder without atrophy raises the question of myasthenia gravis. Facial diplegia is common in Guillain-Barré syndrome. Ophthalmoplegia may occur with Guillain-Barré syndrome, Fisher variant or Wernicke's encephalopathy. The cavernous sinus is frequently life-threatening. The cavernous sinus syndrome is frequently life-threatening. It often presents as orbital or facial pain, orbital swelling and chemosis, fever, oculomotor neuropathy and trigeminal neuropathy affecting the ophthalmic and occasionally maxillary divisions. Cavernous sinus thrombosis, often secondary to infection from orbital cellulitis, a cutaneous source on the face or sinusitis, is the most frequent cause. Other etiologies include aneurysm of the carotid artery, a carotid cavernous fistula, orbital bruit may be present, meningioma, nasopharyngeal carcinoma and other tumors, or an idiopathic granulomatous disorder, Tolosa-Hunt syndrome. In infectious cases, prompt administration of broad-spectrum antibiotics, drainage of any abscess cavities, and identification of the offending organism are essential. Anticoagulant therapy may benefit case of primary thrombosis. Repair or occlusion of the carotid artery may be required for treatment of fistulas or aneurysms. Tolosa-Hunt syndrome generally responds to glucocorticoids. So this is the anatomy of the cavernous sinus in coronal section. Optic chiasma, this is the anterior cerebral artery, this is the internal carotid artery. So here we can see the internal carotid artery. So this is the oculomotor nerve, trochlear nerve, ophthalmic and maxillary division of the trigeminal nerve, whereas you can see the abducent nerves lies in the center. You have the sphenoid sinuses here, the hypophysis is here, optic chiasma here is the anterior clunar process, this is a subarachnoid space. These are the coverings, pia mater, arachnoid member and the jutra mater. So the third, fourth and sixth nerves are commonly involved along with the fifth ophthalmic, maxillary and mandibular divisions. So the cranial nerve syndromes, it could be at the orbital apex, it could be the superior orbital fissure, lateral wall of the cavernous sinus, retrosphenoid space, apex of the petrous bone, internal artery canal, pontocerebellar angle, jugular foramen, posterior laterocondylar space, posterior retroparotid space. So these are all the cranial nerve syndromes. In the orbital apex we have second, third, fourth, first division, fifth and sixth nerves. The cause is invasive fungal infections, amyloidosis or granulomatous disease. In superior orbital fissures, third, fourth, first division, fifth and sixth nerve. Second is not involved. Second is involved in orbital apex, whereas in superior orbital fissures, second nerve is not involved. So invasive tumors of the sphenoid bone or aneurysms. In the lateral wall of the cavernous sinus, third, fourth, first division of fifth, sixth often with proptosis. Cavernous sinus could be because of infection, thrombosis, aneurysms or fistula of cavernous sinus, invasive tumors from sinuses and cellular turcica, benign granuloma responsive to glucocorticoids. Retrosphenoid space, it is second, third, fourth, fifth and sixth, large tumors of the middle cranial fossa. Apex of the petrous bone, it is fifth and sixth, petrositis and tumors of the petrous bone. Internal auditory meatus, it is seventh and eighth, tumors of the petrous bone, dermoids, infectious process, acoustic neuroma. Pontocerebellar angle, it could be fifth, seventh, sixth, eighth and sometimes ninth, acoustic neuroma and meningioma. Jugular foramen 9th, 10th and 11th, tumors and aneurysms. Posterior lateral condylar space 9th, 10th, 11th, 12th, tumors of the parotid gland and carotid body and metastatic tumors. Posterior retroparotid space 9th, 10th, 11th, 12th and Horner syndrome. So tumors of the parotid gland, carotid body, lymph nodes, metastatic tumors, and tuberculous adenitis. So these are the wonderful concepts of the cranial nerve disorders. The other concepts of clinical neurology I put in a book called Exam-Oriented Clinical Neurology, written by me, Dr. Sreenivas, published by White Army. This book will be very useful for students appearing for clinical neurology exams, and if interested, this book could be purchased. The other book I wrote is Focused Neurology, published by CBS Publishers and Distributors, written by me, Dr. Sreenivas. This book contains all the essential elements of theoretical neurology in a question and answer format. So this book will be very useful for students appearing for theory, orals, and Viva OC. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. So if you have enjoyed and liked, please subscribe to my YouTube channel. But as I said earlier, there are 50 episodes of Prime Neurology. If one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. We are done with another episode of Prime Neurology. So if you have enjoyed these concepts, please share, like, but subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my web page, Dr. Sreenivas Concepts. Thank you. Bye.